PI of DynAIRx AI.
So I'm going to talk just briefly about some of the insights in the DynAIRx project, which is around using or developing digital tools and AI solutions to support the delivery of structured medication reviews. So Tony told us there about what the challenge is, a lot about the challenge around polypharmacy and how that's a challenge for both patients who take many medicines and for healthcare services in general. And one of the proposed solutions to tackle that is the structured medicines review, which was introduced into the GP contract a few years ago now. And it's intended to be a shared decision-making process for people who are living with multiple long-term conditions and taking many medicines, usually driven and delivered by pharmacists and GPs, although there are other specialists involved, with the intention to try to reduce medicines-related harm and some of those hospitalizations that we see. The major challenge that we face and my pharmacy colleagues face in delivering these is how do you identify who is most at risk of harm and who is most likely to benefit from one of those reviews from the many, many thousands of patients who take more than 10, more than 15, even more than 20 regular medicines. So we're trying to use the data to be able to understand risk and benefit relationships, but as a case finding tool as well to identify patients, because we know that kind of providing feedback to prescribers helps to reduce medicines related harm. We know that that can be done by looking at combinations of particularly risky medicines. What's getting more difficult as we all age and acquire more conditions is that many people will have multiple of those potential drug combination harms. So actually it's about finding the individuals rather than finding the medicine's harm. So how we can take those kinds of prescribing dashboards one step further. And what we're using in DynAIRx is trying to use our local population data, a combination of primary and secondary care data, in particular high-risk patient groups, to try to build these dashboards, A, to find the patients, and B, to help support the actual delivery as well. But the first step in doing that is understanding from the people who are both doing these kinds of reviews and in receipt of them, what are the barriers and to being able to do them well, and what sorts of things would make it easier. So we've done a number of focus groups and interviews now with a large number of people involved, both from the primary and secondary care interface with these kinds of processes, and looking at the tools that they currently have, the digital tools that they use, and some of the proposed solutions, so the things that have been used as a way of presenting data more that can lead to more efficient decision making. Sorry, this is it's quite a small slide for me to read, but one of the ultimately the take-home message is there's a lot of barriers. There's a lot of barriers to being able to do this well, and a huge part of that is around time, the amount of time that it takes, the detective work that you need to do for complex people who've had the acquisition of multiple conditions over a decade or more, and that there are barriers both at a practice level, at the delivery of a practice level, but also at an individual medication level. There are particular prescribing groups that are very challenging. So we've just put that the kind of the qualitative output in our latest paper, but yeah, essentially the take-home messages are around the time, the complexity. Many people sort of say, surely there are digital tools now that can do this better. Surely that, it shouldn't be that I have to navigate 18 different systems to find different letters and where different information is held. And that there is this real challenge about communication between primary and secondary care, that there are specialists starting medicines and then the umbrella care of managing multiple specialty drugs that's left to the GP in a stretched appointment time. And so we asked clinicians as part of those workshops and interviews, well, what do you think, what would you want from digital tools? And again, the take-home message is loads of things, that they had a huge wealth of ideas about all the things that you could potentially do, learnings from AI in other areas and how you might apply that to health data. So in the interest of time, just a couple of snapshots, but the thing that came up time and time again was around timelines, being able to view people over time, how things have changed over time, connecting diseases and the prescriptions and how that has evolved over time was a big must for people who are doing this kind of work. So that then led us on to workshops, which have only just been completed. So I don't have all of the data to show you, but essentially we did workshops with GPs and PCN pharmacists to ask the question, what do you need to ensure that the digital tools that are being developed are useful to you? And a lot of that work was done through giving them examples, and we asked people to sort of rank the options of what was available. And that's for two tools. One is a case finding tool. So what data do you want to be shown at the front door to be able to decide where you're going to put your limited resource? If there's only so many reviews you can do in a day, how do you want that information presented? And then also for the development of a tool that's more of a one-to-one tool. So that's just an example of the kind of way that this was done in those co-development workshops. We're trying to stress the importance of developing a tool that's clinically useful and that is co-developed with people that are going to be using it. The next stage is to do our patient workshops. So for the people who are in receipt of these reviews. And a couple of the preliminary themes of it hasn't all been analysed fully yet, is about incorporating risk scores into searches. So at the moment, people are finding patients through numbers, really, who's taking the most medicines in my practice. Being able to incorporate different risk scores to find the people most at risk was felt to be very valuable and an achievable task. And then also sort of personalised simple metrics, so things that can be flagged so that things can be done in advance. So if somebody hasn't attended for ages for blood tests that need to be done in order to have an effective review, then that's something that an AI system could do quite easily. And other determinants of risk was the other one. So people were very keen that people were not missed just if people have disengaged from care, if they're not filling their prescriptions, things like that. Those are things that are not easily surfaced with our current search metrics. There were a number of barriers, just to finish on that a lot of people, I think it is really important that we recognise that for clinicians, this is a huge ask to be developing AI-driven tools. I certainly wasn't taught about it at medical school, and I'm sure most weren't. So people were sceptical. They felt more comfortable with kind of gold standard authoritative sources. They see it as a potential time burden. The time taken to understand the tool could be better used elsewhere. But everyone agreed that the tools need to be transparent. That was their major requirement. And so I'm very grateful. It's a collaborative effort as DynAIRx, so grateful to the whole team.